afternoon, and welcome to NOAA Rounds 4, Session 7. Please join me in welcoming our presenters, Dr. Shehzad Ali and Dr. Ava John-Baptiste, who are both associate professors at Western University. Dr. Shehzad is Canada Research Chair in Public Health Economics at the Department of Epidemiology and Biostatistics in the Schulich School of Medicine and Dentistry. Dr. Ava John-Baptiste is an associate professor with appointments in the Department of Epidemiology, Biostatistics, the Department of Anesthesiology and Perioperative Medicine, and the Schulich Interfaculty Program in Public Health at Western University. The topic that they're going to present on today is a systematic review of modeling guidelines of infectious disease models and social determinants of health. Just some quick housekeeping before I hand it over to them to introduce the topic more thoroughly. We will be using GoToWebinar's question capacity in the meeting user interface. You should see something that says questions, and you can post questions there. We will take the questions in the final 20 minutes of the presentation. So if you want to queue them up as we go, that is just fine. You don't have to wait to pose the questions until the end. And all participants will remain muted through the webinar. And at the end, I will present a reminder about our coming rounds next month. And with that, I will hand it over to Drs. Ali and Jean-Baptiste.
Thank you very much. I appreciate it. Thank you for that introduction. And on behalf of Shehzad, I'd just like to thank you all for joining us today. It's a pleasure to present to the network of Alberta Health Economists. Our topic, infectious disease models and social determinants of health, a systematic review of modeling guidelines. And so I'll start off the presentation, and then I will give the floor to my colleague in a little while. So I'll go to the background slide. I don't know if are you in charge of advancing? Thanks so much. So our motivation for this topic arose from the fact that very early on in the COVID-19 pandemic, it became clear that there were disproportionate effects on marginalized racial, ethnic, and socioeconomic groups. What also became clear was the importance of infectious disease modeling in informing public health policy at all levels, despite empirical evidence that exposed significant inequalities in the impact of the pandemic. For example, in the United States, early on, it was clear that in counties with a large proportion of African-American residents, that the infection rates and mortality rates were higher. It was our sense that most infectious disease models were based on an average population approach and it ignored social factors. Next slide. Yeah, thanks so much. So the components. Now, this systematic review of modeling guidelines is the first or one of several projects around this topic of social factors in infectious disease models. The second, we're currently engaged in a systematic review of published COVID-19 models to identify what social factors have been incorporated, if any, and then how they were incorporated. We are conducting a survey of health system decision makers to identify policy questions related to the health protection of socially and economically disadvantaged groups that might be addressed using infectious disease models. And we're also conducting a survey of infectious disease modelers to identify barriers and facilitators to incorporating social factors into these models. All of this, we hope, will inform future work with our colleagues, modeling colleagues, on how to properly and thoroughly incorporate social factors into infectious disease models. So in terms of the methods of our systematic review, our protocol is in the Prospero registry, and we use search terms to identify the relevant domains, modeling guidelines for infectious diseases. We searched publications from January 2000 to August 2020 and also conducted a search of the gray literature and citation searches for included articles. So when screening records, we wanted to identify studies that were focused on guidelines for modeling infectious diseases, where the subject of the studies were human spread of disease only. The guidelines were pertinent to how to develop mathematical or statistical models of infectious diseases, and the subjects of the models that were subjects of the guidelines should focus on direct or indirect epidemiology of infectious disease, either at the individual, population, health, or non-system levels. Guidelines could focus specifically on infectious diseases like tuberculosis or influenza, or broadly on infectious diseases in general. We excluded studies that focused only on animal models or animal spread of a pathogen, qualitative or behavioral studies, studies focused on in vitro modeling of pharmacodynamics or pharmacokinetics, model-based guidelines pertinent only to chronic diseases that were with no infectious cause, and guidelines related to the management of infectious diseases, whether that be screening, population interventions with no focus on modeling. And we excluded those that were non-English in publication language. So I'll move on to our results now. Here's our PRISMA diagram. A search of Medline, Embase, Cochrane Library, and Web of Science identified 631 unique records, all of which were screened. After screening, we retrieved 16 full texts to assess for eligibility, of which 6 were excluded. Exclusion reasons were, for example, they were reviews without any sort of framework or synthesis of guidelines or recommendations, or original modeling studies or qualitative analyses. Of the full text that 10 were included, and through the search of the gray literature and citations identified included studies, we identified an additional 9 for a total of 19 studies that are included in the qualitative synthesis that we're presenting today. The guideline focus is summarized here. The vast majority, 13, were general in their focus, so focused generally on infectious disease modeling. 1 each focused on zoonotic diseases, influenza, Chagas, COVID-19, neglected tropical diseases, and HIV. 14 of the 19 studies specifically made reference to incorporating social factors. Amongst those 14, by far the most common was age, with 13 guidelines recommending age be incorporated into infectious disease models. 5 each addressed sex and gender and socioeconomic status. And when I say socioeconomic status, that includes references to income, deprivation, marginalization, etc., and SES. 3 each recommended incorporation of race and ethnicity, migration and immigration patterns and geography, and 1 each employment status, housing density, and cultural beliefs and religion. And so here I'll hand off to my colleague, and Shehzad will talk about the recommendations and our synthesis of the recommendations across these studies.
Thank you, Eva. So before I begin, I should say that this is still work in development. There were quite a few guidelines that we found, and the process of synthesis is still underway. One of the other things I should mention is that recommendations are not always clearly presented in these guidelines. A lot of the times these guidelines would present arguments for taking into account different factors, but not necessarily make clear recommendations. So we are going to present some common themes that came out of these these guidelines. So we've grouped them into 5 different categories for the presentation today. The first one is to appropriately categorize modeling disease dynamics in infectious disease models. The second aspect is explicitly taking into account heterogeneity of disease impact, both in terms of impact of the burden of illness and also impact of policymaking. This then feeds into informing decision making and considering social factors within that space. Some guidelines, not many, talk about considering inequities, and then there are some technical recommendations that were made, which we will be talking about towards the end. So the first one and the most common aspect of recommendations has been consistently saying that we need to take into account social factors because they improve model accuracy and model precision. And if we look at the arguments are based on the fact that individual characteristics are different. Individuals have different levels of susceptibility to infections, the way they interact with their environment and with the health system is different. And because of these differences, unless we take into account all this variability in individual behavior and the conditions, social conditions that they live in, we will not be able to produce accurate and precise estimates. So a number of guidelines focus on social factors with the primary motivation of improving model accuracy and precision. And this is the predominant thing that we noticed in most of these guidelines. So talking about some of these elements, so host susceptibility is an important area. And as Eva was saying, a huge amount of literature started appearing fairly early during the pandemic, identifying that multimorbidity and a number of other social conditions are not randomly distributed in the population. And therefore, there are certain social groups in the society who are much more susceptible to being exposed to the COVID-19 pandemic and have different levels of impact. There's also consideration in relation to contact patterns and mixing patterns. So, for example, if you're living in an urban slum in a developing country, then your interaction with other individuals living within the same environment is going to be much greater compared to an academic who lives in Canada and can work from home. Similarly, if we look at multi-generation housing, which is way more common in developing countries and also common in certain social groups living in more developed economies, those individuals are sometimes at higher risk of exposure, because even if one person in your multi-generation house is going out for work or for different reasons, they may be bringing that risk of infection back home with them. So because this risk is not randomly distributed, therefore we saw that the number of infections was also socially distributed. So one of the areas that a number of these guidelines highlight is that we need to take into account particularly age, sex-related factors, which are directly related to mixing of individuals in the community. The other thing to consider is individual circumstances. and individuals may want to change behavior, but they may not be able to change behavior in the same way as other social groups. So, for example, if you are part of the poorest socioeconomic quintile in a population and you hold multiple jobs, you are in the poorest group, then you may not have the same level of freedom to work from home or to quit your job, and therefore the change of behavior is again not randomly distributed. It affects certain social groups much more than others. Misinformation, misperception, again, there are some studies that have documented this and then clearly suggest that certain communities have higher level of misinformation, partly because of differences in the level of education, but also because public messaging is often geared towards the common denominator, and it leaves out particularly vulnerable groups. Another thing that has been mentioned in a number of studies is regional heterogeneity. A number of these models sort of borrow contact matrices from other settings, and sometimes don't take into account regional variation. So even within Ontario, there is significant variation, which relates to social factors. The second aspect is heterogeneity of disease impact, which is related to the first part that we just discussed. But there is an important difference here. The motivation for the first aspect that we just discussed was primarily to improve model accuracy and precision. Here, the idea is that we want to find out if there are any identifiable groups that have different levels of impact, risk, or impact of the pandemic or its policies. So we want to develop models that are mindful of the fact that certain groups have a much higher level of exposure and much higher level of impact, both in terms of how the pandemic is affecting them directly or through indirect effects of lockdown and other policies that are in place, such as mental health impact of the pandemic. So there are certain distinct characteristics that we need to think about, both in terms of disease burden and policy impact, and these are both spatially and socially distributed differently. One of the other interesting elements and important elements is disease-driven movement. So, as an example, when we were in the early early phase of the pandemic, a number of countries introduced lockdown very suddenly. So, examples from developing countries that we have seen, where we've seen that a large part of the labor force that was working primarily in urban centers, when lockdown was put in place, they lost their jobs, and as a result, they did not have any money to live in large urban cities, and a huge number of them had to return back to their villages. As a result, they also took the risk that they had been exposed to back to their communities. So again, this level of social distribution has a direct impact on how the pandemic progresses, how it impacts certain social groups. Another important element that a number of recommendations have, a number of guidelines have asked to look into is the heterogeneity of treatment effects. And when we talk about treatment effects, we are particularly thinking about health policies. And policies may not have the same level of impact across all social groups. And it's interesting that when, as Ava was saying, we are doing this large systematic review of infectious disease models that have come out in the last year or so. And what we have noticed is when policies are being evaluated in infectious disease, through infectious disease models, the heterogeneity of treatment effects, particularly looking at how different social groups are affected by different policies is not always an important focus of these studies, which was surprising to us. And again, also looking at modeling guidelines, this has been mentioned in a few guidelines, but has not been explicitly mentioned in most of them. So it is possibly because the focus is primarily on producing these models that are accurate and precise at a population level, while at the same time ignoring the social differences. There are also behavioral dynamics which are different. So individuals in different social groups may not have the same behavioral response, or may not have the freedom to have the same level of behavioral response as others. There's also social variations in components of services. So, for example, health services, the level of exposure to health services, and there have been several studies that have documented this both in Canada and outside, that the utilization of health services and general level of exposure to health services has a social gradient, and it's sort of both in terms of socioeconomic status, race, ethnicity, and a number of other factors. Use of health services is different. And when we are developing these policies that are delivered by the health system, or health system plays an important role in delivering these services, then we have to be mindful of the fact that social groups, it's not a uniform level of utilization across social groups. This then feeds into how these infectious disease models feed into decision making. So a clear recommendation that came out of a couple of guidelines is that mathematical models should not work in a vacuum. And if you are developing models in a vacuum, then your predictions may not materialize or may not show at the level that you were predicting. And even if they do realize at an average population level, they will possibly hide a number of inequalities that are of concern, particularly during the pandemic. So we need to think about this is what the guidelines have recommended, that we should be thinking about values and preferences of communities, resources and choices that are available to local populations. So, if we start shutting down services, the options are of accessing other services is again not uniformly distributed across geographies and across social strata. Cultural beliefs obviously also play an important role, and the social context of the target population is something to consider. And one of the other things that has been brought up by a number of guidelines is that the decision makers' population of interest, that needs to match the model population. So particularly in the early phase of the pandemic, a lot of models were borrowed from other countries or other regions, and the population distribution did not necessarily match the decision makers' population of interest. And even if they did, what those models allowed was some level of flexibility to change some parameters in the model, but not really taking into account the full spectrum of social distribution. One of the other things to also think about is health system considerations. So modeling the impact of interventions by varying intervention eligibility. And as we know, for example, for vaccines, the eligibility of vaccines is different across different countries. Within a certain within the same country, sometimes they do vary between different regions, and it's something that has evolved over time. So one of the things, and there has been a lot of discussions, and Eva and I have discussed this a number of times. What was very interesting to see is in the year 2020, and especially in the first few months of 2020, when there was a lot of talk, both in the media and in the speeches made by politicians, as well as academic papers, there was a lot of concern around the socioeconomic, ethnic differences and in the level of exposure and outcomes of the pandemic. And based on that, our feeling at that time was that a lot of these models will be focusing on how implementation strategies, particularly those that relate to health systems, for example, where will the testing centers be based? What will be the level of coverage of testing, and then vaccines and compliance, etc. It seemed like this whole concern for the social gradient has not really come out as strongly as we thought it would come out, based on the literature that we saw coming out in the first few months in relation to the impact of the pandemic. So another thing to think about is subnational health system capacity, which is not even within Canada. We know that health system capacity varies significantly, and testing and preparedness of these to respond to the pandemic is not uniform. And when we are developing these infectious disease models, an important consideration is how subnational health systems vary, both in terms of social distribution as well as health capacity, and how that health capacity will then potentially exacerbate the inequities within regions and between regions. The fourth one is considering inequities, and I'm just looking at the time. I think we are okay for time. Hopefully. So in terms of considering inequities, and as I was saying earlier, inequities don't really feature a lot in these modeling guidelines, which is very surprising. These are a couple of guidelines, and there is two others that do explicitly talk about inequities, and I do sort of like how this particular study very clearly in the Canadian context talks about First Nations and population patterns of abuse and poverty and historical trauma. And all of this, interestingly, shapes both the impact and the response. And but again, infectious disease models, although this is a 2015 guideline, infectious disease models not necessarily sort of take into account these considerations explicitly. And the hope is that if you take a population average approach, hopefully the impact will be equitably distributed somehow, by magic, I should say. But we know that these things don't always work out the way we expect. So one of the other things to consider when we're thinking about inequities, one guideline sort of clearly mentioned that surveillance systems may only capture the severe cases. So we're only capturing individuals who show up at the testing center or seek medical care. So we know that prevalence is typically underestimated, and case fatality rate is often overestimated, because this is based on individuals that we see. And this has been discussed a lot in the scientific literature in the last few months. But the important thing to consider, as well as one of the guidelines clearly mentions, is that it's not just that this underestimation or overestimation is randomly distributed in the population. We know that certain social groups are much less likely to come in contact with the health system. If you're holding 3 jobs and living in poverty, even if you have symptoms, you may not go and get tested unless your workplace requires you to, because of fear of losing a job and not having the time to get tested. the fact that surveillance systems are based on these population averages, that could potentially exacerbate inequities, and then this is something that infectious disease models should be explicitly considering and not always do so. The next one is data synthesis. Again, a number of studies, particularly early on during the pandemic, when infectious disease modelers and policymakers were talking about using evidence from other epidemics in the past, and to see how effective lockdown may be and other policies that were on the table. A lot of this evidence was based on population average evidence that existed out there, and these parameters that were fed into infectious disease models often ignored that a policy that may work for one community may not work for others, and could potentially even harm certain communities. So some further clear recommendations that have come out of our review of guidelines is that when infectious disease modelers are developing these models, they need to involve people who understand inequities. Particularly, they need to work with communities, stakeholders, partners, and not just at the stage of disseminating the results or findings of infectious disease models, but also at the stage of formulating research questions and developing these frameworks. So this early involvement is absolutely fundamental to ensuring that the models are mindful, or modelers are mindful, and policymakers are mindful of potential inequities. Also, knowledge translation and communication has to be bi-directional, rather than modelers developing the models and then presenting the findings to the receivers. One of the other things that we noticed in our reviews is model guides and particularly papers are very technical and heavily mathematically oriented, which, to be honest, sometimes we have struggled reading these papers as well. Technical guidelines tend to be so technical that the policymakers often struggle to understand these models. So non-technical model guides are extremely important. The final section that I want to talk about is modeling considerations. So a number of models have been developed, as we are aware. Early in the pandemic, there was compartmental models were the most commonly used models, starting with SIR model, SEIR models, and its variations. And then as things developed further, people started moving towards individual-based models or agent-based models. And there was also an appreciation that individuals are not just randomly interacting with others in the community, and people live in their networks. And the level of interaction within networks is also socially driven. So certain communities have a higher level of interaction. They may have bigger networks, and others may have smaller networks. And also, this is also geographically and spatially driven as well. So then we sort of started moving towards a more complex agent-based models. And one of the assumptions that people make is that individual-based models are more accurate, which is often the case, but not always. You could also develop sort of population-based models where you take into account different characteristics of the population that you are interested in, and then potentially look at subcohorts to the limit that it allows you to. And at some point, it just becomes too challenging, and then it makes sense to go towards individual based models. But anyway, we're not going to sort of talk too much about the technical aspects. The focus really here is on thinking about social factors and how they should be explicitly considered when we are developing these models. The next thing is when you move towards the agent-based models or individual-based models, and there are sort of different names and different formulations of these models that exist, they may be more accurate and they may better reflect the social factors better than population-based models. But they also tend to be computationally intensive, and that's one of the things that some guidelines very clearly mention, that these models are both technically more cumbersome. They are also computationally more intensive. The data requirement is also much higher for these models, and they may not always be available. So one of the recommendations is that you start with simpler models and sort of add in complexity as required. One of the other things to think about is the modelers need to make sure that the generated population from the model generated population is very close to the target population that we are considering. And a lot of the times we have to use microdata or survey data to create our synthetic populations or population for these models, and modelers need to be mindful of the fact that a number of social groups are underrepresented in microdata, and which we sort of discussed earlier. And if you are using this information, which is potentially biased in favor of one group or the other, then the model predictions may also be biased. So just to, sort of in terms of conclusion, we want to emphasize the fact that the guidelines have recommended, although not as strongly as we probably feel about this, that ignoring social factors could potentially exacerbate inequities, both in terms of the burden of illness and also in terms of the policy impact. And we need to sort of take into account these social factors, particularly when we are looking at developing models that inform future policies. So that's an important takeaway for us from these. So we have a number of collaborators, and you can see the list here, and they are based both in Canada, US, and the UK. So this is a good team, and we wouldn't be able to do this without this team. And then the work, as Eva briefly mentioned, the work was funded by the SMDM CDMI initiative, and yeah, we want to thank our funders for this. And I'll just stop here, and I think we are ready to take questions. Thank you.
Great, thank you. Perfectly on time. So our first question from Kyle is, can you provide some guidance or references for how to quantify community values, cultural beliefs, and social context so that they can be modeled? Are there more specific parameters that modelers should look for?
So I'll try, and maybe Eva can then add. So it's a good question, and I think that was one of the challenges, I would say. And then I saw a couple of papers came out early in 2020 where they recommended that we need to take into account both social factors as well as community preferences into developing these models. And a significant challenge was that data to inform these models were lacking, and not just in Canada but outside as well. But I think a number of surveys have been conducted in the last year or so There was a study that I saw published in The Lancet, which looked at people's preferences and how they vary between social groups, preferences in terms of vaccine, for example, perceptions in different communities. There is also a huge amount of data in terms of both within Canada and outside, based on administrative data, census data. Data sets exist that tell you the distribution of multimorbidities and how that varies between social groups, the level of contact that people have and how that varies, also in terms of employment and how that varies across social groups. So a number of these data sets exist, and I know that some colleagues in the UK have pulled together these different references to understand what is causing this high burden of illness and the potential direction that we should be going in. But I think it's a combination of inequalities or social gradient not being a key priority, certainly in the early phase of the pandemic, and having limited data. But I think a number of sources do exist, which can be pulled together.
Yes, and I would just add to that, just to highlight the recommendations that Shehzad mentioned about decision maker engagement and the importance of involving a more broadly represented group at the model conceptualization stage, because even in the absence of data, having an understanding, for example, of different approaches to aging and how that varies from, let's say, immigrant populations in Canada versus sort of the more traditional approach that older adults are maybe more likely to be residing in multi-generational households due to the social structures of those communities. And so even in the absence of data, just an understanding that the ability to protect older adults from COVID-19 infection is likely to differ, and sort of knowing where to look for data to support those estimates is extremely important, even from an early stage in the conceptualization of the model.
Well, great, thank you for that answer. Our next question is from Deborah Marshall at University of Calgary. She says, thank you for this comprehensive presentation. With the aim of applying models in practice, are you able to suggest examples of models that have been used or applied directly in decision making?
So that's an excellent question, Deborah. Thank you for that. We have in our systematic review of models, the one we haven't presented that work here today, but we struggled a little bit with the scope of the modeling work that has been going on to inform policy decision making. In that systematic review, we focused on published models, and we've also looked at models in the archives. But due to we have been engaged at tables where modeling is informing policy decision making federally with PHAC, and a little bit exposed to what's happening at provincial levels. The truth is, much of these are not published, and so they are conducted, and I think understandably and appropriately, in direct response to decision maker needs, often very rapidly, without even the opportunity for publication. So in terms of the models that are informing policy in Canada, much of it eventually gets published, and we certainly have identified Canadian publications that I could share with you individually. But in terms of the examples that have been in use to inform policy, some of that is really difficult to quantify and appraise. I hope I'm getting at your question. I don't know, Shehzad, if you had something to add to that.
Yeah, I just want to add one more thing, and I don't know if Eva shares the same feeling. And as you said, we are part of a number of tables where these things are discussed, and it's interesting and sometimes frustrating to see that when we are part of a group of modelers, social considerations and social gradients are not really at the top of the list. And even when we have discussed some of our work, which was received with interest, the feeling is that the modeling community is often interested in producing better predictions for the general population, and then the focus is on identifying key parameters that work for the general population. So while we have seen some examples, this is unfortunately is not the focus of models still, which is surprising to us.
Yes, and actually, just one more thing. I will highlight one example that comes to mind, which is in the medical archives, related to vaccination policy. Carolyn Colgan in BC and others, and I think Chris McKay was involved in that work as well. I think that's one of the examples where social factors have been incorporated, looking at essential workers and their high level of contact with each other and their potential for contacting high-risk individuals, and the benefits of targeting vaccination to that group outweigh a sort of general approach. So that's, I think, one of the more recent examples that comes to mind, and that work is maybe familiar to you already or in the public domain. But it is in part because of the computational challenges. I think, in all fairness to modelers, it is often overlooked incorporating social factors.
Okay, sorry about that. I think my internet froze for a second at the moment when I had to ask the next question, of course. Our next question from Ellen is asking, what could be done to make some of the population distribution information and other key data sets more accessible for modelers, noting that sometimes it's really a big effort to look around to gather this information.
Yes, I think that there have been some efforts to make data more available in the COVID-19 context. I think, for instance, the University of Toronto has a kind of an open data portal that I think a lot of the modelers rely on. However, I think the level of detail information required, particularly to incorporate social factors, is lacking, and that's really part of the challenge. Now, from the background that many of you would be familiar with, health technology assessment and models that are done to inform and estimate the cost effectiveness of health technologies, typically cohort models, decision analytic models. We have developed approaches where sort of absence of data isn't intended to be a barrier to incorporating a parameter that is clearly potentially important into a model, and that that we can incorporate parameters of plausible range, and of course, evaluate our models, understanding the uncertainty in those parameters, and in the uncertainty in possibly in the model structure as well. I realize that's much more difficult to do in an infectious disease modeling framework because of the much higher level of computational complexity that's already involved, and the complexity in implementing the model. So this is part of the challenge, and it's our hope that we will provide more of the impetus to collect this data and make it available. I think without specific reference to specific data sets, that general issue is what I'd like to highlight. Shehzad, I don't know if you had something to add to that.
Yeah, no, I think you covered almost everything. I just want to add one more thing, that I think what there needs to be these common platforms where decision makers meet and their priorities are documented and shared, because currently what we have seen is that there are several groups and tens of groups that are developing their own models, addressing their own local policy makers' concerns, which is fantastic. But I think a number of these groups are working on initiatives that are often not available to other parts of the modeling community, and some of the concerns, particularly around social inequalities, are shared across Canada by all decision makers. But if these efforts are not shared in the same way, then we may end up developing a model that addresses the London Middlesex population, and those particular efforts may just remain within the confines of that geography. So I think bringing together both the decision makers as well as modelers is something that is absolutely fundamental. And there are, as Eva said, there are efforts, a very successful effort that have been made. We're part of this PHAC group that's a pan-Canadian group of modelers and decision makers, and but because there is such large heterogeneity within the country, the discussions are often around producing better estimates for a particular region, and I think with greater effort in terms of characterizing the social distribution within each region, this could be much stronger.
Thank you. Our next question is a little more specific. And from Aaron, wondering if there was any guidance around distributional equity in cost effectiveness analysis, specifically thinking about that integration of health economic outputs in infectious disease models.
Yes. So in the guidelines that we focused on, there was very little reference to issues of cost, and much less so cost effectiveness. In part because the way we targeted the guidelines, we were focused on infectious disease modeling guidelines quite broadly. We could have taken another course where we tried to address methods that could be relevant to infectious disease models, but weren't restricted to infectious disease models. And that would have, apologies, that would have made for a much broader target set of studies. So in short, the guidelines, we don't have any specific references to cost effectiveness beyond what may have just been included related to HTA guidelines in some of these studies that had a bit of a crossover. I don't know, Shehzad, if you wanted to add to that.
Yeah. No, I agree, Ava. There's a couple of things that come to mind. So Richard Pittman's paper, 2012, which was a NISPOR group guidelines, they do talk about some elements of cost effectiveness, which is, I think, a good place to start. And then also Richard Cookson's work that you may be familiar with, Richard Cookson and Mikdad Asaria and the group from York on distributional cost effectiveness analysis. Then I also came across a reference that was published last year, which I think it was in Value in Health, if I'm not wrong, but I can share the reference separately, which kind of touched upon this, looking at cost effectiveness analysis and bringing in societal preferences into cost effectiveness analysis, and sort of building on some of the previous work. But I agree that these infectious disease guidelines that we had identified, there was not a lot in there, and I think some of the work that is done by Mark Jitt, for example, he also briefly mentions about cost effectiveness within the infectious disease setting, but again, you know, it's an area that is covered to some extent, but not comprehensively, I think.
Okay, great, thank you. And that was the last question in my queue. So unless another one pops up immediately, I think we're good. We're very close to time. I want to thank you both so much for such a great presentation and good engagement with the questions. Thank you so much. And, you know, virtual applause from me and our muted audience. As a reminder for everyone, our next NOAA rounds will take place on April 21st. So please mark your calendars and visit noah.ca to register. Likewise, if anyone has, you know, a final question that they think of, or anything that they wanted to follow up on with the presenters, you can feel free to connect with noah@ihe.ca, and we will make sure the presenters get your question. Thank you very much.
Oh, thank you very much for the opportunity, and thank you, Kate and Nicole,
yeah, we appreciate
organizing.
it.